There we go. Right. Sorry about that, everybody. Just struggled with my computer, which froze now. So as a reminder to those who might be here for the first time, the weekly hematology deep dive is not just for hematologists, it's for anybody interested in expanding their knowledge on hematology. We try to focus it on trainees and to make it very practical and clinically relevant. So feel free to share our link to anyone you want. We really welcome people from all specialties, even if you're not directly in hematology, hematopathology or clinical hematology. The weekly meetings are recorded, and the recordings can be found on the Blood SA website, as you can see on the screen. And we really encourage you to be interactive, to ask your questions. I'm sure there will be many questions on this topic today. And also, if there is anybody who wants to add a friend or a colleague to our mailing list, please ask them to email Melanie, and you can see the email address there. If you are from South Africa, CPD points will be automatically submitted to the HPCSA, or at least a request. If you are not from South Africa, and welcome to all our colleagues from the rest of Sub-Saharan Africa, then email Melanie so that she can get a certificate for you. We also really value and act on the feedback you provide us at the end. So please give us honest feedback, tell us what you liked, what you think can be improved, and the team will definitely attend to that. Would like to remind and encourage everyone to join us for the 16th Annual Hematology Oncology Symposium that will happen in less than 2 months. We're six weeks away. And also for those who are submitting abstracts, there's a huge prize up for grabs to go to the EHA conference sponsored next year. So I really want to encourage everyone to submit your abstracts for the research component, but it's going to be incredible. This year, we're looking at both the pathology and the clinical side, the benign and the malignant, so a huge balance. I don't think you will see any conference that is so broad in its scope these days. Most conferences now focus on either a benign topic or malignancies, etc. And we really want this to be clinical, but benign and malignant, and also really want to encourage the pathologists to join us. And there will be a number of pathologists speaking, and also people from the transfusion services. This is our A team that puts together the deep dive program and logistics. Thank you, Estelle, Gerdien, Melanie, and Bridget. And with that, it gives me great pleasure to now introduce Dr. Jacques Malherbe, who will speak today on PNH and the role of complement pathway inhibition. Now, Jacques, I know very well. I had the privilege of working with Jacques when he was training as a clinical hematologist at the University of the Free State. And also, as you can see on the screen, after completing his MBCHP at the University of Pretoria, he came to do internal medicine at the Free State, roundabout at the same time that I started working there as well. And we were very, very privileged to have him as one of our top trainees ever. And he's currently the head of clinical hematology. Jacques is a super optimist. He always goes, not the extra mile. I think because he's a long distance cycler, I think he's got 100 miles extra for every patient. And I've always known Jacques to fight to the last drop to get whatever he can for his patients. And I really respect you, Jacques. He's got also very interesting other interests. This man is a specialist on whiskey. I've never been able to beat him at chess. Not that that is such a big thing for me, but I can tell you he's good. So I challenge you to challenge him on my behalf and let me know if you've beaten him. And and then he's, as I said, he's a cyclist. He's taken part in the Cape Epic, and he finished as part of the top 10 in the 2023 APSA Cape epic in the Masters category. So, Jacques, great to have you. Over to you.
Thank you, Vernon, for that very gracious introduction. Yeah, and thanks for the opportunity to speak on this very interesting topic on this afternoon's deep dive. I'm just going to quickly share my screen. All right, so this afternoon we will be talking about PNH and the role of complement pathway inhibition. So just a disclaimer, this talk was sponsored by AstraZeneca, and just the usual disclaimer slide. So before we go into PNH, I thought it's important to look at some history. The classical complement pathway was discovered in the 1890s by Jules Bordet. And in the mid 1890s, he was investigating bacteriolysis by immune serum. And then he showed that bacteriolysis results from the combined action of two factors in blood serum. And he discovered a non-specific heat labile factor, which he initially called alexin, and that was later changed to complement, and a specific heat stable or sensitizing factor, which we eventually figured out were antibodies. He furthermore showed that agglutination, which is mediated by the antibody, preceded lysis by complement. And for his discoveries in immunology, not only he had multiple discoveries in immunology, he was awarded the Nobel Prize in 1919. So the classical pathway was the first pathway that was discovered. The second pathway that was discovered is the alternative pathway in 1954 by Pillemer and colleagues. But this was actually initially met by a lot of scorn by the scientific community, and they criticized these labs' work, that it was just an artifact. But then eventually his and his colleagues' findings were validated in the 1960s and 70s. The discovery of the alternative pathway took a more convoluted route. And then the lectin pathway was only described in 1987 by Akida and colleagues. So the complement system is an ancient, very ancient host defense system. And I found this very fascinating, that we can trace the origin of the C3 and factor B genes at least 1.3 billion years. These genes are at least 1.3 billion years old, as they are found in the cnidaria, which are jellyfish and corals, as well as in protostomes, worms, snails, nudibranchs, and so forth, and as well as earthworms. So the central part of the complement system is very, very old. Now, the higher vertebrates, such as us and bony fish, share the same set of complement genes, and the evolutionary divergence happened 500 million years ago. So it truly is a very old system. As most of you will know, it is very closely involved in innate immune responses, but it's also a complement to antibody-triggered responses. It's a complex system with close to 60 plasma and membrane proteins described, and there's 3 distinct but overlapping pathways and a common terminal pathway. So the complement system has 3 major functions. Firstly, identification of foreign material and damaged self through opsonization, and this plays a critical role in cellular debris clearance, the elimination of these targets via phagocytosis or lysis via the membrane attack complex. It also plays a role in the promotion of inflammatory and immune responses to these targets. The anaphylotoxins such as C3A and C5A is involved in vasodilation, mast cell degranulation, and cellular chemotaxis. And it also plays central roles or important roles in angiogenesis, tissue regeneration, and mobilization of hematopoietic progenitor cells. This system requires tight control to prevent tissue damage, and nearly half of complement proteins are regulators of the system. And we have membrane regulators. We'll go into this in a little bit more detail later. The membrane regulators that we know is decay accelerating factor, CD55, or membrane cofactor protein, CD46. And then there's plasma regulators, which are synthesized in the liver, such as factor H, I, and C4b, C4 binding protein. Before we look at the pathways, it's maybe just useful to say something about the nomenclature. So the various complement proteins, on upon activation, they are often lysed into fragments, and large fragments are denoted B, and they bind cell surfaces and continue the cascade onwards. And then small A fragments are released into the circulation. You'll see here that C3A has functions in inflammation, the anaphylotoxins, and then so just something on the nomenclature. So the pathways as depicted here, I've put them in order of their evolutionary development. The alternative pathway is the most ancient system. It's an ancient surveillance system, and it's the original extracellular complement system. And it is continually active at a low tick over, where at about 1% per hour, there's a labile alpha ester bond in C3, which automatically leads to the formation of C3b. And then if it lands on healthy self tissues, it's inactivated by regulators. And if it engages debris or pathogens, then the feedback loop is amplified. So the alternative pathway agents are C3 and C3b, with the help of factor B, factor D, and properdin, leads to the formation of the C3 convertase, which through amplification leads to the formation of C5 convertase and the eventual development of the membrane attack complex. The lectin pathway, so a lectin is a protein that binds a sugar. And there's repetitive sugar patterns on the surface of pathogens, and that's different from the sugar patterns on our own cells. You have pattern recognition molecules such as mannose binding lectin, ficulin, colectin 10, etc., that binds these sugars. And then you have pattern recognition molecule associated serine proteases. This is such as MBL associated serine proteases, MASPs, that then, if you look at the lectin pathway, the lectins bind the sugars, the MASPs are then activated, converting C4 to its activated form, converting C2, and then lead to the formation of the C3 convertase and moving into the terminal pathway. The classical pathway is activated by antibodies. IgM, IgG1, and IgG3 strongly activates this pathway. IgG2 only weakly. There's some controversy or discussion if IgA truly activates the pathway. Some evidence is for and some evidence against it. Just noted that the classical pathway is not activated by IgD, IgE, or IgG4. And there's some other proteins such as CRP and a few other proteins that can also activate the pathway. But classical pathway activation runs through C1, activating C4 and C2, formation of the C3 convertase, and the same eventual formation of the membrane attack complex and the formation of opsonins and the anaphylotoxins. So it's worthwhile to look at the feedback loop of the alternative complement pathway. So we've mentioned that C3 has a label thioester bond, which lead to the automatic formation of C3b and C3a. The C3b binds factor B in the plasma, and then with the cofactor, factor D, the alternative pathway convertase is formed by the formation of factor BB and factor BA. Properdin then stabilizes this alternative pathway convertase, and then will convert further C3 to C3b and C3a. So this forms a feedback loop. C3b that's deposited by the classical or the lectin pathway can serve as a nidus for amplification of the alternative pathway. And this amplification will then eventually lead to C5 convertases and the membrane attack complex forming. This I actually just put in for interest. It's fascinating to look at the structure of the membrane attack complex. It's been very well described. It forms this, so it's the sequential building of the membrane attacks complex starting at C5b, C6, C7. It attaches to the membrane, C8 is added, and then 10 to 16 molecules of C9 is added to form this tubular structure which attaches into the membrane and forms a pore. And these images down here show this. These are actual electron micrograph pictures of the membrane attack complex on membranes, and it's got this sort of split washer type of configuration. So fascinating complex protein. So complement regulation, as I've mentioned, is critical in health, and the pathways are regulated or inhibited at multiple levels, at the activation level, at the amplification level, and at the membrane attack level. The classical and lectin pathway is inhibited at the activation level by C1 inhibitor. And this happens in the plasma. So in the classical pathway, C1 inhibitor binds to C1, leading to dissociation of the C1 component. So you'll see here in the stop panel, the C1 complex that's binding the antibodies to lead to activation of the pathway. If the C1 inhibitor binds this C1 complex protein, it dissociates into different components and doesn't activate the pathway anymore. And then in a similar fashion, in the lectin pathway, the C1 inhibitor blocks the active site of the MASPs. And as some of you may know, that C1 inhibitor also plays other important regulatory functions, such as in coagulation, the contact system, fibrinolytic system, and then importantly in the kinin generating systems, and deficiency of C1 inhibitor is obviously a cause of hereditary angioedema, which we won't speak about further. So on the amplification level, or the regulation of the convertase formation, you have membrane proteins playing an important role, as well as plasma proteins. So important examples of membrane proteins include decay accelerating factor, or CD55, membrane cofactor proteins, which is CD46, and then there's various others that have been described. And then there's plasma proteins such as C4b binding protein, which regulates C4b containing classical pathway and lectin pathway convertases. And these regulators of amplification function in three ways. They either prevent the formation of the convertases, or they lead to disassembly or dissociation of the convertases. This is called decay accelerating activity. And they can also lead to limited proteolytic cleavage of C4b and or C3b. And this proteolytic cleavage requires factor I, and a cofactor such as membrane cofactor protein, CD46 on cell membranes, or factor H in plasma. As you are aware, deficiency of factor H and factor I lead to atypical hemolytic uremic syndrome, or complement-mediated thrombotic microangiopathy. This bottom panel just describes what I'm saying. So you have C3b on the membrane. Membrane cofactor allows binding of brings factor I close to the C3b, which then allows proteolytic cleavage of the C3b on the membrane surface in activating it. Regulation at the level of the membrane attack happens again in the plasma phase or fluid phase, and in the fluid phase, vitronectin binds the C5b to 7 complex, and it prevents membrane attachment. And then on the membranes, CD59, which is also called membrane inhibitor of reactive lysis, or protectin. This is a protein that's widely expressed on multiple cell membranes, and as you know, it is glycolipid anchored. And CD59 binds C8 and C9, which then leads to inhibition of the final part of membrane attack assembly. So it halts it at the C5b to 8 phase. So you don't get the addition of the multiple C9 molecules to form the spore. I found this a really nice summary of what we've spoken about now. It also shows some areas where inhibition occurs. This is I think this is a very nice article to look at if one is interested in drugs targeting the complement pathways. Shows the C1 inhibitor inhibiting the lectin and classical pathways, factor I and H, C4 binding protein as the plasma factors, others like complement receptor 1, CD55, CD46, inhibiting the convertases, and then the inhibition of the membrane attack complex. So complement activation is implicated in numerous diseases, and goes, I think, through all systems in the body. I think a few ones to maybe just highlight out, especially the ones in red, where complement is the main driver of disease, and anti-complement therapy play a key role in therapy. We all know about PNH as an important example. Cold agglutinin disease has also got a complement inhibitors, although complement is not the primary driver of the disease, it plays an important role. Atypical hemolytic uremic syndrome, or the complement-mediated TMAs, C3 glomerulopathy, age-related macular degeneration, neuromyelitis optica, as well as generalized myasthenia gravis. This is where a lot of the development in anti-complement therapy is happening currently. So it's not a surprise that there's a lot of development of various agents looking at all phases of the complement system. And I found this is a relatively old publication, 2019, so things have changed since then. Some of these agents have already been approved, like APL2, pegcetacoplan is approved, and iptacopan is approved. But this gives a nice summary of where targets are and where drugs are in the development of these agents. From that Lancet publication earlier this year, this is the currently approved complement inhibitors with the addition of 2 extra in PNH, which we will mention. But in PNH, we have eculizumab, ravulizumab, pegcetacoplan, and 2 others. The anti-C5 ECU and Ravu is also approved in atypical hemolytic syndrome. or the hemolytic uremic syndrome, AHAS. ANCA-associated vasculitis has a C5 receptor 1 inhibitor registered. Eculizumab and ravulizumab is registered for myasthenia gravis. Cold agglutinin disease has an anti-C1s inhibitor, sutimlimab, registered. And there's even a complement inhibitor registered for COVID-19. There's also various drugs still in the late phase of development, and this anti-MASP3 in PNH may be something of interest to us in South Africa moving forward. So let's get to PNH. So as looking at the pathogenesis, as we all know, PNH is an acquired PIK-A mutation in multipotent hematopoietic stem cells. And these stem cells are able to self-replicate and thus establish a clone. The PIK-A gene is on chromosome X, and only a single hit is required to cause disease due to lionization in females, that there's always in each cell in the body one X is inactivated, and obviously males only have one X. And the gene is is responsible for the enzyme that's involved in the first step of GPI anchor synthesis. Mutations are unique to a patient, so there's no mutational hotspot. And currently, the exact mechanism of mutation is unknown, because it's not in a hotspot, and it's usually that there's no evidence of radiation, mutagenic chemo, or a DNA repair defect is seldomly seen in PNH. And the very close association between PNH and acquired aplastic anemia suggests an immune attack on hematopoietic stem cells provide a conditional survival advantage to these hematopoietic stem cells that carry this mutation. Interestingly, I wasn't aware of this until the preparation of this talk. There are some other initiating mutations described. So the PIK-T gene, which I assume is a similar GPI type anchor gene on chromosome 20q, has been described rarely if in patients with a germline mutation that then acquired a somatic mutation on the other allele. And then there's a syndrome of germline loss of CD59, which have a PNH-like syndrome with relapsing immune-mediated peripheral neuropathy. So one of the important components to the establishment of clinical PNH is clonal expansion or selection of this hematopoietic stem cell that carries the mutation. And you require this to have disease manifestations. There's various mechanisms has been described, and it's not fully worked out exactly how this happened, but there's three main theories. There may be, the first theory is immune escape. The second one is a selective advantage for clonal expansion, and neutral evolution. So in immune escape, so generally these hematopoietic stem cells that have this mutation does not have a selective advantage, but it's been shown that they have protection for immune-mediated destruction. And we know that 65% of aplastic anemias have small PNH clones. So the PIK-A mutation and growth suppression of the unaffected, so you have growth suppression of the unaffected hematopoietic stem cells in such as aplastic anemia, MDS, and there's even cases described in PMF, but that's very rare. Then the PNH clone enlarges because the other cell lines are suppressed. Sometimes an additional mutation may provide selective advantage, and then you get accelerated proliferation or reduced apoptosis. So in some cases, it's due to additional mutations that do create the selective advantage. And an interesting one is that that we sometimes get that just stochastically or randomly during periods of bone marrow regeneration, one or more clones expand, stochastically. And this is sort of evidenced by findings that in some patients you get spontaneous clonal extinction and spontaneous remission, which is an interesting thing happening where just in periods of bone marrow regeneration, these clones come and go. So PNH is a rare disease, 1 to 10 cases per million. But this may be a significant underestimation because some patients remain minimally symptomatic or even asymptomatic and remain undiagnosed. And I think this would also be much higher in certain parts of the world, for instance, in South Africa or other parts of Africa. The median age is in around the 30s, although childhood cases are reported. And we've certainly had cases from the 20s to 30s to even older, up to the age of 75. There's no racial or ethnic association, and males and females are equally affected. Sorry, my phone's ringing. So in an international registry of 1,600 patients, more than 93% of patients were symptomatic and had poor quality of life. The most common symptom were fatigue and dyspnea. About 60% of patients report hemoglobinuria, abdominal pain and bone marrow suppression, just under half of patients, erectile dysfunction, a significant finding. And interestingly, in our trial patients, this was one of the first things that the patients were very happy about once they go on to therapy, that this resolves. Chest pain in 33%, thrombosis was seen in about 16% in this series, and 14% renal insufficiency. Another retrospective review of 220 PNH patients, about half of patients had neutropenia and thrombocytopenia, and significantly here, 15% developed pancytopenia by 8 years. So anemia is the main manifestation of PNH, and it's multifactorial, or the etiology may be multifactorial. They get intra and extravascular hemolysis. So the intravascular hemolysis is easily explained by the membrane attack complex, which predominates in untreated patients, leading to intravascular hemolysis via the MAC. But there's also a component of extravascular hemolysis due to deposition of opsonins and mostly C3d. And then that there's receptors for this on macrophages and then lead to phagocytosis. In complement inhibitor treated patients, you obviously knock out the membrane attack complex, so there's more complement fragments on cells, or the cells survive, and they get a Coombs positive extravascular hemolysis. So that's the main etiology for the anemia, but there may also be a significant component of the underlying or associated bone marrow failure syndrome. So the well-known PNH-AA overlap. Usually aplastic anemia precedes a PNH diagnosis. And we've often seen that it then becomes apparent or develop hemolytic PNH post-immunosuppressive therapy. And occasionally aplastic anemia develops in a patient with established hemolytic PNH. So occasionally they may have associated myelodysplastic syndrome, and there's rare cases of primary myelofibrosis described. Important to note that PNH is almost never found in patients with inherited bone marrow failure. So the presence of a PNH clone probably almost completely excludes inherited bone marrow failure as a differential for your patient presenting with aplastic anemia. Due to the chronic hemoglobinuria and shedding of iron-laden tubular cells in the kidneys, they often have concurrent iron deficiency, which complicates matters. And just to note that if you aggressively treat the iron deficiency, you may have a period of increased hemolysis due to increased production of red cells. So you may have an increase in hemolysis after correcting the iron deficiency. The degree of hemolysis is dependent on the size of the clone and the size of type 1 versus type 3 cells, presence of inflammation, which lead to stimulation of the complement system, such as in infections or surgery, can lead to increased hemolysis. And as I mentioned, iron depletion have an initial increase in hemolysis. The PNH is also associated with thrombosis, which is often in atypical locations. Typical syndromes include Budd-Chiari or hepatic vein thrombosis, portal, mesenteric, splenic veins thrombosis, inferior vena cava, and cerebral sagittal sinus and other cerebral vein thrombosis. Venous thrombosis it's much more common than arterial. And the exact pathogenesis is incompletely understood, and it's, again, a multifactorial story. Free hemoglobin due to the intravascular hemolysis lead to nitric oxide scavenging and vasoconstriction, and possibly also lead to endothelial activation and tissue factor expression. There may be procoagulant microparticles floating about due to the hemolysis. And then also deficiency of anticoagulant and fibrinolytic factors that are GPI anchored. And examples of this include tissue factor pathway inhibitor, proteinase 3, and urokinase plasminogen activating receptor, or UPAR. The increased levels of C5a or anaphylotoxin leads to pro-inflammatory and prothrombotic cytokine production. There's the specific risk factors for thrombosis include larger clones, so especially if the granulocyte clone is more than 60%, more severe hemolysis will lead to increased risk of thrombosis. And there seems to be there's some evidence that certain ethnic groups are more prone to hemolysis, and it's especially US data. Black patients have a higher incidence of thrombosis compared to Hispanic, and Hispanic are more than white and Asian patients. Another important component of PNH is the smooth muscle dystonia, and this is, as you all know, is due to hemoglobin scavenging nitric oxide, and you have increased vascular and smooth muscle tone that leads to abdominal pain, erectile dysfunction, fatigue, esophageal spasm, as well as renal insufficiency, and which is further worsened by renal hemosiderosis and tubular dysfunction. And then also an important complication of pulmonary hypertension and the effects thereof. PNH is classified into hemolytic or classic PNH if hemolysis is the prominent symptom. In these patients, the LDH is typically more than 1.5 times the upper limit of normal, and in untreated patients, they usually have very high LDHs. Leukopenia and thrombocytopenia are usually normal. The platelets and white cells are usually normal, or modest. They may have a modest leukopenia and thrombocytopenia, which is asymptomatic. And in these cases, the clone size the granulocyte clone is usually more than 60%. And the bone marrow will be cellular with erythroid hyperplasia and no significant dysplasia or hypercellularity. Subclinical PNH is if there's no substantial anemia-related symptoms or any other complications like thrombosis, pain, or organ dysfunction. And in these cases, the LDH is typically less than 1.5, and usually the clone size is less than 20%, and you'll have a normal or near normal cellularity on bone marrow. And in patients with PNH with associated bone marrow failure syndrome, the bone marrow will meet the criteria for aplastic anemia or MDS. And the hemolysis-related findings depend on the clone size and is quite variable. I'm not going to go into too much detail on the technicalities of diagnosis, but it's relatively straightforward with the use of flow cytometry. One of the reagents used is with the good sensitivity and specificity is fluorescent aerolysin, or the flare, and this is a bacterial aerolysin that binds the GPI anchor. And it's important to note that you need to have at least 2 independent flow cytometry agents on at least 2 lineages to confirm a presence of a clone. The obvious one, CD55 and 59, but then also CD14, 15, 16, 24, 45, and 64. A very important message is that you don't determine your clone size on the red cells because they are being hemolyzed, so you will underestimate your clone size if you look at the red cell clone alone. Just to note that effective therapy with complement inhibitors lead to an increase in the red cell clone size because you're saving these cells from hemolysis. The cells are defined as PNH type 1, which has got normal expression, PNH type 2, which has got partial expression, and PNH type 3, which has got absent expression. And it's been shown that sometimes you've got more than one clone, that one clone leads to partial expression, another clone as absent expression. So there may be clonal complexity in some patients. So all patients with any significant leukopenia or thrombocytopenia should get a bone marrow to assess for underlying bone marrow failure syndrome. So moving on towards treatment, in subclinical PNH, we do watchful waiting and supportive care. In PNH with severe bone marrow failures and bone marrow failure, the focus of the treatment is on the underlying bone marrow failure disease. So if they are transplant eligible, that is the route to go. A matched sibling donor is preferred, but these days matched unrelated or even haplo transplants are increasingly being used. There's only observational studies and case reports, but in these reports, 50 to 70% long-term survival with myeloablative conditioning, and it seems reduced intensity conditioning may be associated with increased survival rates of up to 90%. For transplant ineligible patients, you will go for immunosuppressive therapy for severe aplastic anemia and treat your high-risk MDSs with hypomethylating agents or other agents if available. So it's important to note that the complement inhibitors are not effective for the bone marrow failure, but they may be needed to control hemolysis pre-transplant or during therapy if large clones are present, which complicates with hemolysis or presents with hemolysis. The supportive care, which is an important component of management of PNH in South Africa, as we don't have access to the complement inhibitors usually. Pain control is a very important component, as many PNH patients have chronic pain which may persist despite complement inhibitor therapy. And this is either due to previous complications of the disease or due to other mechanisms related to inflammation and hemolysis. Anemia will require folate supplementation. Iron supplementation should happen if they're confirmed iron deficient. So don't routinely give them iron. You only give it if they're confirmed iron deficient, because they may actually be they may be iron overloaded if they're chronically transfused. Just remembering that initially they may have an increase in hemolysis, which may require urinary alkalization, ensure good hydration to prevent renal failure. Transfusions is used if they're symptomatic or hemoglobin less than 7. Other options have limited evidence, but I think all of us treating these patients in South Africa have used these. So growth factors such as GCSF and EPO may be effective in maintaining stable counts. Androgens such as danazol I've used frequently, and patients do seem to maintain better counts with that. Chronic immune suppression is not generally recommended due to the complications. Although steroids may reduce hemolysis in some patients, often prohibitively high doses are required. if you don't have anything else available, it may be worthwhile to use it and see if patients respond. Some of my patients used increased dose of steroids during episodes of hemolysis and to be able to manage anemia in that way. So the mainstay of therapy is complement inhibitors, and there's currently 5 complement inhibitors approved by the FDA. So the terminal complement inhibitors is the C5 inhibitors, eculizumab, which was approved in May 2007, and then the ravulizumab, which was approved for PNH in December 2018. I should note that South African registration for ravulizumab is pending. AstraZeneca say that hopefully by first half of next year. Alternative pathway inhibitors include pegcetacoplan, which is a C3 inhibitor, which is approved in May 2021. Danicopan, which is a factor D inhibitor, approved in April 2024 this year. And then the last one to be approved just last month is iptacopan, which is a factor B inhibitor. So the complement, the C5 inhibitors were the first on the block, and the one we all know about is eculizumab. It's a humanized antibody, and it's given at the intravenous infusion at a fixed dose, initially 600 milligrams weekly for 4 doses, and then 900 milligrams a week later, and then every 2 weeks thereafter. The registration trials were the Triumph and the Shepherd trials. The numbers of patients are 87 and 97. The Triumph trial was a phase 3 randomized double-blind placebo-controlled trial. And it was a 26-week trial, which looked at hemoglobin concentrations in the absence of transfusions. Hemoglobin stabilization happened in 49% of eculizumab treated versus 0% in the placebo-treated patients. And there was 0 transfusions in the eculizumab group versus 10 in the placebo group. In the Shepherd trial, it was an open-label, non-placebo controlled trial, which showed an 87% reduction in hemolysis and LDH concentrations and an improvement in formalized fatigue scores and a 50% reduction in transfusions. There's an open-label extension of 187 patients from the Triumph and Shepherd, and an earlier pilot study showed a 98% 3-year overall survival. The 4 deaths were unrelated to therapy, and this survival was comparable to age and sex-matched controls. And there were 4% thrombosis during on this extension, or incidence of thrombosis in 4%, and this was compared to 32% prior to the initiation of complement inhibitor therapy, and renal function improved and stabilized in 93% of patients. So ravulizumab was the next one registered, and it differs in 4 amino acids from eculizumab, and this leads to improved pharmacokinetics due to increased neonatal FC receptor antibody recycling. It has a weight-based dosing. There's a loading dose on day 1 and 15, and then the main take-home point is that maintenance dosing is every 8 weeks, a much better schedule compared to every 2 weeks for eculizumab. The 2 registration trials is the Champion and Champion 301 and 302, these trials were non-inferiority trials comparing ravulizumab with eculizumab, and essentially showed that ravulizumab is, in terms of efficacy, similar to eculizumab. It was comparable. This moves me on to the alternative pathway inhibitors. The first one registered is pegcetacoplan, which is a pegylated peptide that targets C3, and it's a subcutaneous injection twice a week at a standard dose. And in the Pegasus phase 3 trial, it was about just under about 90 or 80 patients. When it was patients with an HB less than 10.5 on eculizumab were randomly assigned to pegcetacoplan versus continuing eculizumab. They had a 4-week running period where both agents were given, and then 41 patients continued with only with pegcetacoplan, and 39 continued with eculizumab. So you see where in the running period, the mean hemoglobin increased, and then the eculizumab monotherapy patients dropped back down to baseline, and the pegcetacoplan patients maintained near normal hemoglobins. And at week 16, there was transfusion independence in 85% versus 15% in favor of pegcetacoplan, and there was a nearly 4 gram per deciliter increase in hemoglobin and greater improvement in fatigue. And this has subsequently been approved for frontline and in patients with suboptimal C5 inhibitor responses. The danicopan was an oral factor D inhibitor. Just to note that the agent that some of us have been involved with in clinical trials is a different factor D oral inhibitor. And we still have quite a number of patients in South Africa on that agent. So danicopan is given at 150 milligrams 3 times per day, and its registration trial is a phase 2 study in 12 transfusion-dependent patients. So low number of patients that led to approval, and they received danicopan in addition to eculizumab. And there were 1 patient that received 2 units of blood in the 24-week study, compared to 50 units in 10 patients in the 24 weeks prior to the study, and the hemoglobins increased from 7.9 to 10.3, and there was also an improvement in the quality of life score with a very significant 11-point mean rise in the FACIT-Fatigue score, and it's currently approved only as an add-on therapy. Iptacopan is the latest one being registered, and it's an oral factor B inhibitor. And it's given 200 milligram BD without regard to food. And there's 2 trials, the Apply PNH, which randomly assigned 97 patients with a hemoglobin less than 10 on a C5 inhibitor, 8:5 ratio, to switch to iptacopan or continue the C5 inhibitor. And you can see here that the patients continuing on the C5 inhibitor didn't improve the HB, whereas those that changed to iptacopan had a marked rise in their hemoglobin. And then the point PNH trial was in 33 complement inhibitor naive patients, and it showed over 24 weeks a significant improvement in mean hemoglobin. And then transfusion avoidance was attained in 95% of patients in the iptacopan group in Apply PNH, and only 26% in the anti-C5 therapy group. And in the single-arm trial, 98% of patients were transfusion independent. So it's now also approved for frontline and in patients with incomplete responses on C5 inhibitors. So now, if you have all these agents available, how are you going to treat a hemolytic PNH when you diagnose them initially? So based on sort of author preference in up-to-date authors and other publications, ravulizumab is preferred as initial therapy. So it's more convenient than eculizumab, and it's less expensive. So there's a US study in atypical hemolytic uremic syndrome showed a 32 to 35% cost reduction of ravulizumab compared to eculizumab. So the alternative pathway inhibitors, iptacopan and pegcetacoplan, are acceptable alternatives. The why ravulizumab is still preferred first-line therapy is the short half-life of the iptacopan and pegcetacoplan leads to a higher risk of breakthrough hemolysis in poorly compliant patients, especially with the iptacopan. If they're not taking their medication, they will get breakthrough hemolysis, which can have significant complications like thrombosis, acute renal failure, and so forth. It also does not inhibit the classical pathway or the lectin pathway, and there's possibly a higher risk of breakthrough hemolysis with infections or other classical and lectin pathway triggers. And I think another important point to mention is there's lack of long-term follow-up that confirms thrombosis protection with these agents. So many authors avoid them in patients with a thrombosis history. Again, I think it depends on what one has available. And there's also no safety data in pregnancy, and because they're small molecules, they cross the placenta, and they should be avoided in patients who may become pregnant and can't take adequate contraception. So so if available, you start with complement inhibitors, preferably ravulizumab. Now, hematopoietic stem cell transplant is effective for the treatment of hemolytic PNH. We've already mentioned that if you've got bone marrow failure that require transplant, that is the route to go. But if you've got a purely hemolytic PNH, a stem cell transplant will be effective or may be effective. But where complement inhibitors are available, it's not indicated due to the known morbidity and mortality associated with transplant. But when we're unable to access these agents, it may still be something to think about. So about 30% of patients on C5 inhibitors remain anemic or require periodic transfusions. There's various mechanisms. I've alluded to the extravascular hemolysis via C3d opsonization, which is the most common and the most important reason for persistent anemia. But there's also pharmacokinetic effects. So you have waning inhibition of the complement system prior to the next dose, and this is more prominent on eculizumab than ravulizumab. And there may be pharmacodynamic breakthrough in settings where you've got increased complement activation, like infection, surgery, or pregnancy, where due to this complement activation, the red cells are densely coated in C3b, and this leads to C5 adopting a C5b-like conformation, which is not inhibited by eculizumab or ravulizumab. There's a high prevalence of intrinsic resistance in Japanese patients due to two C5 polymorphisms, so that disrupts the target epitope. So in Japanese patients, there's a much higher incidence of failure of C5 inhibitors. The anemia may be worsening of the underlying bone marrow failure syndrome, or there may be other cause of anemia, most often iron deficiency. So you'll look for these things. How do we manage a patient who's getting breakthrough on a C5 inhibitor? If persistent hemolysis is the cause, the preferred option, again, if available, is to switch to pegcetacoplan or iptacopan. You may consider the addition of danicopan, obviously dramatically increasing cost. Or you may think about shortening the dosing interval of primarily eculizumab, but I suppose possible also with ravulizumab, to manage pharmacokinetic breakthrough. You can, if the bone marrow failure is the reason, you'll treat that, and you can replace iron and folate. So what are the adverse events of these agents? So I think most of you will be aware that the main concern is life-threatening infection with Neisseria meningitidis. So the guidelines recommend vaccination plus antibiotic prophylaxis, and this will be PenV 500 milligram BD or azithromycin 500 milligram daily. And they need antibiotic prophylaxis for the duration of the complement inhibitor therapy. And this recommendation is born from the fact that there's a 0.5% risk per year despite vaccination on patients with on C5 inhibitors. And this is 1,000-fold increased compared to the general population. Now, importantly, you need to vaccinate with both the serotype ACYW as well as serogroup B vaccine. So from experience from our clinical trials, only the ACYW vaccine this is the typical meningococcal vaccine that we use in South Africa is available. The serogroup B vaccines are not registered in South Africa. So this is, I'm not sure if this has changed in the interim, but something to keep note of. And it's very important that the vaccination schedule should be up to date. For the standard vaccine, if they're less than 3 years old, it should be 3 years after the initial vaccination schedule, and then every 5 years. Over the age of 7 years, the vaccination should be every 5 years. With a B serotype, B group, serogroup B vaccine, it's 1 year after the primary vaccine, and then every 2 to 3 years. And patients should be educated to immediately seek medical attention if they have any symptoms, fever, or anything suggestive of meningitis. It's also the other encapsulated organisms such as Streptococcus pneumonia and Haemophilus influenza B they're also at increased risk, and vaccination is also recommended, especially with the alternative pathway blockers. I haven't been able to figure out why that is a stronger recommendation to vaccinate against strep pneumonia and Haemophilus influenza in the alternative pathway inhibitors. These agents have got few other serious toxicity. A headache occurs in 50% of patients initially, which resolves after a few doses, and this is possibly due to increased nitric oxide levels and vasodilation of cerebral vessels. Back pain and nausea may be an issue in some patients, and then iptacopan is associated with diarrhea and lipid abnormalities. I think the biggest toxicity is the financial toxicity. These agents are extremely expensive. Recently got a quote for iptacopan in the South African setting. It's not registered, but a quote of around 7.9 million rand per year. And communication is that we are looking at similar costs for the agents that will be registered or maybe will be registered. So just a few specific scenarios. How do we manage thrombosis? Historically, 40% of patients had thromboembolic events, and it's the leading cause of death in patients not on complement inhibitors. In acute thrombosis, you anticoagulate and use thrombolysis as per the normal indications. The duration needs some discussion. If it's a provoked thromboembolism and a patient is then well controlled on a complement inhibitor with an LDH less than 1.5, most would give 3 to 6 months anticoagulation and then stop, although some experts give indefinite anticoagulation. If there's additional risk factors, then like a thrombophilia or any other risk factor adding to the thrombosis risk, you need to individualize the decision. And an unprovoked new thromboembolism on effective complement inhibitor therapy need indefinite anticoagulation. I think it's just maybe important to note that, and this I think is important in our complement inhibitor naive patients, because anticoagulation is less effective for treating and preventing thrombosis in these in PNH patients, and due to the very strong effects of the complement system on thrombosis, and anticoagulation more often fails than in non-PNH patients. That's why complement inhibitor therapy is so important. So thromboprophylaxis you don't routinely give prophylaxis if there's no history of thrombosis, but you should give prophylaxis during at-risk periods if they're going for surgery or around delivery and so forth. A few other special scenarios in surgery, as mentioned, can precipitate hemolysis. So if you can plan the surgery, it must be close to the most recent complement inhibitor infusion. And asymptomatic patients with large clones that are not on complement inhibitor therapy, some experts will initiate temporary complement inhibitor therapy around the time of surgery to prevent thrombosis. And in pregnancy, important thing is to make sure the patient's iron and folate replete. They may require increased transfusion during pregnancy. And currently, the only complement inhibitors that's acceptable in pregnancy is ravulizumab or eculizumab. But due to the volume of distribution increase in the third trimester, they may need dose adjustments. And there's associated, and these two agents are associated with improved maternal outcomes and no evidence of fetal risk. So prior to the availability of complement inhibitor therapy, there was an 8 to 20% maternal mortality, depending on your series and literature that you look at. There's 45% incidence of spontaneous miscarriage, and more than half of pregnancies ended in premature delivery. So pregnant patients should get low molecular weight heparin during the last trimester, and 8 to 12 weeks, and for 8 to 12 weeks postpartum. So for women considering oral contraception or contraceptive or needing contraception, if PNH is not well controlled, non-hormonal contraception methods are preferred, or the lower risk hormonal methods such as Mirena, and this, I think, will need to be discussed in detail with the patient. I think this is especially important in our population with limited access. So last two slides is, what is the prognosis of PNH? So it's a chronic disease with significant morbidity and mortality. In a series of 220 patients in the pre-complement era, this is in 1996, the median overall survival is 14.6 years, which sounds long, but remember that most of these patients are diagnosed in their 20s and 30s, and that is a significantly impaired survival compared to their age and sex matched controls. And at 5, 10, and 15 years, the survival was 78% at 5 years, 65 at 10 years, and 48% at 15 years. So significant mortality at 15 years. And the 8-year rates of pancytopenia, thrombosis, and MDS were 15%, 28%, and 5% respectively. So high incidence of thrombosis, 28%. And since in the era of complement inhibitors, as mentioned before, mortality seems similar to age-matched controls. So these are incredible therapies with dramatic impacts on the quality of life and survival of patients with PNH and also other complement conditions that we may get consulted about, like complement from TMAs or atypical hemolytic uremic syndrome. But I think the biggest challenge that we face is, how are we going to ensure access to these agents? As I think everybody, and I've mentioned some prices, is aware that the cost of these treatments are very, very high. I don't have answers to this question. I think it's a question we face on a day-to-day basis, not only in the treatment of PNH, but all over medicine, and especially in hematology, where the amazing science lead to amazing therapies, but access just seems to be becoming more and more challenging. And this is a big discussion for another day. So with that, it's the end of my talk. My references are there. The slides that have specific references, I referenced. The other slides without references came from the up-to-date topics as shown there. All right. Any questions?
Thank you so much, Jacques. I think one can hardly choose a more complicated topic, if I must say, maybe just for me, but I think the complement system, like, I think it's worse than porphyria. I want to start off. There's a couple of questions in the chat, and we'll get to them in a moment, but I want to ask you, in an environment where we do not have easy access to these treatments, I was wondering about what other supportive measures we can offer these patients apart from anabolic steroids and, the usual treatments. And I was actually thinking in terms of advice that we can give patients for their day-to-day, about exercise and stress, hydration. As an example, I just saw one of our PNH patients this morning, and this is not just him. I've seen it with one of our other patients as well. Whenever they get dehydrated, they hemolyze. The one I saw this morning, Fiona Watt, that works with us, has noted that he hemolyzes when he flies down from the East London to us, or the Eastern Cape to us, suggesting that there might be something with the pressurization of the aircraft, and that could have an impact. And I was also just thinking back to a publication we did many years ago, Jan Smeerema and I, on the use of arginine as a source of nitric oxide. Very natural thing, easy to access, not expensive, where we were able to show with catheterization of the heart that we could decrease pulmonary pressures in a patient with pulmonary hypertension after splenectomy for spherocytosis. So I was wondering if you had any ideas about this. Should we advise anything in terms of lifestyle, diet, etc.?
I don't have any comment on the arginine thing. That's very, very interesting. But I agree with, what we do, I mentioned in terms of actual therapy, the danazole, transfusion, looking at the other factors of anemia, growth factors, those things that I discussed in the talk. But I do think I agree with you that there's certain triggers of hemolysis that one can try and manage. And I have also seen in patients, if they increase their exercise or exercise heavily, that hemolysis may increase. I do think sort of graded moderate exercise would be advisable. And the hydration thing, I think, is very important. I'm not sure if dehydration specifically triggers further hemolysis, but it definitely contributes to the worsening renal function. And what I've noticed in our patient is that their kidneys are very, very sensitive to the effects, and they've got dramatic decreases in their renal function. Sure. When the weather is hot and they don't drink. So yeah, we advise our patients to increase their fluid intake, and I think it's very important. It makes a difference. I think it's also important that they get educated on thrombotic risks. If they have any surgery or any scenario, admission to hospital or long-haul flights, I think one should discuss the possibility of thromboprophylaxis with them. And I think it's also important to discuss in females if they're not on complement inhibitor therapy, what the implications of pregnancy is, and that there is significant risk of adverse outcomes in pregnancy, and to discuss appropriate contraception. And they should think about their decision about, I mean, it's a very important decision for a young woman or a young family, but that they whatever decision they make, that they make an informed decision on that, and to manage that. So I do, yeah. And then I think furthermore I mean, that they get, although if they're not on complement inhibitors, they not at an especially increased risk of infection, but that they are aware that if they get an infection, a flu or anything, that they increase their fluid intake. We also give them citrus soda, sort of urinary alkalinization, when they have significant hemoglobinuria. That does limit the amount of renal toxicity of the acute hemolysis or hemoglobinuria. So, and that if they have some features of infection, that they seek help early so that it's treated effectively if it's something that can be specifically treated. And I think another important thing to inform them is that if they need vaccinations, influenza or COVID or whatever vaccination, that they may expect increased hemolysis around the vaccination due to the immune stimulation, and should be aware to manage the hemolysis with increased fluids and urinary alkalinization. So that's what I can add.
Great. Thanks. And I just want to add to your comment on the kidneys. We've done some kidney biopsies, and surprisingly, even though they're often iron deficient from the hemoglobinuria, we've seen quite significant iron deposition in the kidneys from chronic hemolysis, more than what I thought one would expect to see. Okay, great. Let me see in the, thank you, Garrick. Garrick has shared a link in the chat for an article that he used when studying. Thank you for that. Yes, then I just want to quickly see. Right, so Garrick asks, Jacques, is there a PNH clone percentage that is diagnostic of PNH? I'm always asked if there's a diagnostic threshold to say someone has PNH. I've read red cells more than 1%, granulosa more than 5% is diagnostic, etc. I suppose, and you can see the rest of the comment there. Do you want to comment on that?
I must say, I'm not aware of a specific cutoff, and I stand to be corrected. But I think that the bottom comment is the most important one. That it's, I think when you've got a PNH clone less than 20%, they're less likely to have significant hemolysis. They may obviously hemolyze during periods of complement stimulation. Yeah, I actually don't have a specific book answer for that, but I think the combination of hemolytic symptoms and findings, LDH, retics, and haptoglobin with PNH clone. I think if you have a significant hemolysis with a PNH clone of 1% or 2%, I think you should think about other things contributing with hemolysis. And yeah, I think it would be unusual to have very severe hemolysis with a small clone. Yeah, I don't know if you have anything to add on to that, Vernon. I didn't
Tomek has also added something. He said, dear Garrick, I found this article useful to understand the clone percentage, and it is about correlating, like you said, with the clinical picture. And then excellent to see Jessie Chow on the call today all the way from the States. Thanks. Nice of you to join us, Jessie. Great to see you. Jessie says, excellent presentation and overview on PNH, given that atypical hemolytic uremic syndrome also involves complement dysregulation, SC5B with thrombotic and renal manifestations. How often may there be clinical overlap between PNH and aHUS upon presentation, given that both can be treated with eculizumab, or are they mutually exclusive entities?
Interesting question. I think that, Jesse, they definitely can be clinical overlap, because you can have a patient with, atypical hemolytic uremic syndrome will present with a degree of fragmentation hemolysis, which the peripheral smear in PNH usually doesn't show any specific finding. There's no spherocytes or fragments usually. There may be a macrocytosis if they've got a significant reticulocytosis, but there's not really any specific peripheral smear findings in PNH. But in AHAS, you'll have fragmentation and then the prominent renal component. The pathogenesis, although they both can be treated by complement inhibitors, is quite different in that atypical uremic syndrome, or the more modern term is complement-mediated thrombotic microangiopathy, is usually due to deficiencies in the inhibitors of the complement system, like factor I and factor H, or antibodies against that. So either congenital deficiency of those inhibitors, or antibodies against factor H, I think is the most common, which then lead to I don't know exact pathogenesis in terms of what, but they basically have a thrombotic microangiopathy that has prominent renal involvement. So I think there's clinical overlap, but I don't think there's pathogenesis overlap in the sense of, it's different processes. I don't know if they're mutually exclusive, but I think they're both rare conditions. So it'd be, I think, very unlikely to diagnose both in the same patient. And so that would be my take on it. I think they both treat with complement inhibitors because they involve dysregulation of the complex complement system. And that's why inhibition of the complement system is effective in treating it.
Thank you. Then Andrew says the most impressive effect on therapy on trial has been improvement of quality of life. PNH is not just an anemic disorder needing transfusion. Caroline Stein from your team, Jacques, agrees. Things like mental clarity, energy, etc. improves, as well as the need for blood transfusions. A lot of people thanking you for a great talk. Andrew says about pregnancy, embarrassed to say, but had a patient fall pregnant on trial. Andrew, I'm sure you're not responsible for that. Obviously, emergency stop of small molecule drug with massive hemolysis, as now has a very large clone at risk. Baby and mum is fine. But I can imagine we had the patient fall pregnant on one of our trials as well, not on the PNH one there. Thanks for the different perspective, Dr. Malherbe. Definitely think I understand a little better for now anyway. Lots of thanks there from different people, so it's really wonderful. Great to see everyone. So just wanted to double check, Jacques, what did you say about autologous stem cell transplantation? Do you just want to repeat that quickly? Did you mention auto transplant somewhere?
Did I say auto? It should be.
Did I see something about auto?
Gosh, I hope not. It's not auto.
I just wanted to double check somehow.
If I said auto, please ignore what I said. It's allogeneic stem cell transplant.
Okay. No, I misread. I just wanted to get enlightened.
Okay. Yeah, no, apologies. It may be that I miss.
But on that note, can I be provocative and say, if we don't have any affordable treatments around, would there be a place for stem cell collection at a time when there's a very small clone spotted and the patient does not have any aplasia, that we can at least partially reset the patient later?
I mean, that whole thing about the stochastic proliferation of the clones, and I mean, I'm not sure if anybody's ever tried autologous in PNH. It's a very good question. I can't answer that, but it may be interesting to think about. But I think the harsh reality is that we're going to struggle, whether you are a state patient or a medical aid patient, you're going to struggle to access these agents, mainly due to cost. So we're obviously very active in trying to look for trials, and there's hopefully some trials on the horizon, and that looks very promising. So we may be able to offer some of our patients therapy based on trials. But other than that, we are quite limited, and one will have to look at innovative ways to access the therapy.
Absolutely. And I think,
Yeah.
fortunately, you've shown us that there's so many new drugs on the horizon that hopefully, well, at least the opportunities for trials are increasing.
Yeah,
I think one of the things I've recognized lately that bothers me greatly is how the rare disease designation is actually being
abused almost. Yeah.
abused by keeping drugs, expensive for a very long time. And I've even I've encountered issues where people do not want to expand the indication, even though it might be logical for certain drugs, because then they would lose the rare disease designation if they expanded to more common diseases, even though the rationale for using it there would be very good. So it's an interesting thing. There's the financial element behind it is obviously a challenge. Andrew is giving us great hope for very cheap biosimilars to be, we hope. But yeah, I think the competition in the market is good. There's a lot of activity. I think there's a lot of new interest by different pharmaceutical companies. So hopefully things will improve. And with that, I would like to specifically thank AstraZeneca, who has sponsored today's deep dive. It's really wonderful that we have people that are passionate about education in these different areas. And I also hope that they will be successful in bringing options to market that is affordable and accessible to our patients. Jock, we are exactly at 17:30. Do you want to make a closing comment?
I just saw one comment from Cecile that any chance of a decreasing price of eculizumab. So I think maybe the generics or biosimilars, as Andrew mentioned. But also, I think this is a big discussion also is our pricing laws in South Africa, I do think, contribute to challenges in getting good prices negotiated with a single exit price and so forth. And I know that in some countries, it's been mentioned that they were able to negotiate significantly cheaper costs of these agents. So yeah, there's, I think, in terms of South African legislation and how prices are determined, there may be some room for improvement there.
Thank you, Jock. Some people have asked for the attendance link again. So just remember, when you registered for this session and entered, you did provide your email address. So that would, if you're from South Africa, automatically lead to being your name being submitted for CPD points. If you're not from South Africa, please email Melanie Davids at the email that I've just provided. And then lastly, if you could click on the link provided earlier to provide feedback on the session, to answer a few questions, that would be really great. I see Bridget has also just given a link for the post-session survey. We would really appreciate your input there. Jock, thank you for a fantastic session.
Thank you.
Led to a lot of good discussion, and we look forward to seeing everybody back next week, Monday. Bye-bye.
Bye-bye, everyone.
This is for post session.